A request has been made for me to explain the case study for the cardiovascular system, and normally we don't do that. However, judging by the number of wrong answers that were in most everybody's case studies, then I think it'd be to everybody's benefit to go through this. So let's go through the case study for the cardiovascular system. I'm going to read it to you. You can read along if you want, or just skip to the parts where we start answering the questions. So the case studies, part 1, emergency. Mrs. Helms came in through the front door of her house with an armful of groceries. She put the bag down on the kitchen counter and called to her husband, "Herb, I'm home. Are you ready for lunch?" She didn't get an answer, so she walked to the living room and found Mr. Helms lying on the floor. "Herb, are you okay?" she asked as she grabbed his shoulder. Mr. Helms responded weakly while clutching his chest. Mrs. Helms frantically called 911. It only took EMS a few minutes to arrive, and the paramedics transported Mr. Helms to the hospital. Upon admission to the hospital, Mr. Helms's vital signs were recorded as follows. In question 1, it does ask, which of Mr. Helms's vital signs and lab values were abnormal? So let's look at them. Systolic blood pressure. Mr. Helms' systolic blood pressure was 90. Normal is 120. So that is definitely low. His systolic blood pressure is too low. It's about 30 points off of normal. The diastolic blood pressure, which is the resting blood pressure for the ventricles and the systemic arteries, is 80. His was 52, so it's lowered by about 30 points as well. So his blood pressure was 90 over 52, and normal is 120 over 80, so those are both decreased. His temperature was 98.9, which is about normal. Heart rate, how many beats per minute? His were 120 and irregular, and it should be 60 to 80. So his heart rate is elevated, while his blood pressure is decreased. The respiratory rate, breaths per minute, his were 33 and labored. Normal breaths per minute is 12 to 20. So his respiratory rate was definitely elevated. And then oxygen saturation, sometimes it's abbreviated as percent sat. His oxygen saturation was 89%, and it should be around 95 to 100%. So he's not getting enough oxygen. His oxygen levels are too low. So that took care of number 1 for us, about the what are his vital signs and lab normals that were abnormal. Just about everything except for his temperature. And then it asked, what type of medical tests would you run? And this is kind of a subjective question, so I didn't really ask too many things, or I didn't really rate anybody too hard on that. But you could order an ECG, which is a measure of the electrical conduit through the cardiovascular, or through the heart. You can order an echocardiogram, which is like a sonogram, so you can watch the heart beating. You could order a chest x-ray. You could do something called blood gas, wherever they draw some blood and they test your oxygen and your carbon dioxide levels, test your blood pH, so on and so forth. Most of you just put an ECG and left it at that, and that's fine. We're not doctors and nurses yet. All right, so on to part 2. Part 2 says cardiac involvement. Mr. Helms was admitted to the hospital with chest pains and shortness of breath. His wife was panicked since her 72-year-old husband had a history of heart disease. After examination and an echocardiogram, Dr. Collins spoke with Mrs. Helms. "I'm very sorry, but your husband has had another heart attack resulting in valve failure. A papillary muscle that controls a valve in his heart has been severely damaged and is no longer working." So question number 1, what is the purpose of blood flow? And again, most of you got this right. Blood flows as a delivery mechanism. It's delivering oxygen to the cells. It's delivering carbon dioxide away from the cells. It's taking nutrients to the cells. So the blood is flowing, is transporting things that our cells need, and then removing stuff that our cells don't need. Now, number 2, describe blood flow through the heart, starting with the blood entering the right side of the heart and including all chambers and valves. And again, this on this slide, it shows you, it's on the next slide where we show the pathway of the flow of blood through the heart. Most of you got this right. You just didn't start in the right spot. When it says start with the right atrium, we're talking about the blood vessels that lead to the right atrium. Now, one of the pre-labs, you had to fill it out for me. You had to just fill in the blanks. And most of you, I'm sure, did that right. So we start with blood flowing into the right atrium through the superior vena cava, inferior vena cava, and the coronary sinus. And then when the right atria contracts, it passes the blood through the tricuspid valve into the right ventricle. Then when the right ventricle contracts, it passes blood through the pulmonary semilunar valve into the pulmonary trunk. Pulmonary trunk leads to the pulmonary arteries, which then leads to the pulmonary capillaries where we have the gas exchange. We're going to bring in oxygen and carbon dioxide is going to leave into the alveolus. And then as blood returns back to the heart, it goes through the pulmonary veins. Pulmonary veins lead to the left atrium. And then from the left atrium, when it contracts, blood passes through the bicuspid, also known as the mitral valve, into the left ventricle. When the left ventricle contracts, blood passes through the aortic semilunar valve into the aorta. And now we're in the systemic circulation. The aorta leads to systemic arteries, which leads to systemic arterioles, and then we have the systemic capillaries. And we have an exchange here as well. The systemic capillaries are delivering oxygen and picking up carbon dioxide. And then we're going to return the blood back through the systemic veins. So the capillary beds lead to systemic venules, which then leads to systemic veins, and then back to the right atrium. So that is the flow of blood through the heart, actually through the entire body, but you get the gist of what I'm saying. Number 3, what is the function of heart valves? The function of a heart valve is to prevent blood from flowing backwards. You always want blood to move forwards. Whatever blood enters the heart has to leave the heart. So if one of the heart valves is not completely closing off and blood is backing up, then it's possible for more blood to exit the heart or more blood to stay in the heart than to leave. Anyway, number 3, the function of the heart valves is to prevent blood from flowing backwards. Number 4, some of you missed this part. What is the function of the papillary muscles? Now, the papillary muscles are innervated by the Purkinje fibers, just like the trabeculae carneae. So whenever the ventricles contract, the papillary muscles contract at the same time. The papillary muscles are attached to cords known as your heartstrings, which are the chordae tendineae. The chordae tendineae are attached to the cusps of the AV valves. So the papillary muscles are attached to the chordae tendineae, which are attached to the AV valves. Now, they don't open or close the valves, and that's the part that some of you missed. The valves are going to open and close depending on pressure gradients. Whenever the pressure of blood inside of the atria is greater than the pressure of the blood inside of the ventricles, then the AV valves will open. So they open due to the pressure. Now, whenever the ventricles contract, the papillary muscles contract at the same time. They pull on the chordae tendineae, and they keep the AV valves closed. They don't actually close the valves. They just keep them closed and prevent them from going backwards, blowing up into the atria, which would be a prolapsed valve. So the papillary muscles prevent valve prolapse. All right, so number 5. Which valve is affected with damage to the papillary muscle in the left ventricle? Well, the papillary muscles are attached to the chordae tendineae, which are attached to the AV valves. So the AV valve that is on the left side would be the bicuspid or mitral valve. So in this picture, this is showing the circulation through the heart. Blood enters into the right atrium. From the right atrium, it goes through the tricuspid valve into the right ventricle. And then from the right ventricle, it goes through the pulmonary semilunar valve into the pulmonary trunk. And then we go to the lungs. And we come back through the pulmonary veins into the left atrium, and then through the bicuspid mitral valve into the left ventricle, and then through the aortic semilunar valve into the aorta. In this picture, we can see the papillary muscles right here. Here are the papillary muscles. Maybe remember it whenever we were dissecting the sheep heart in the anatomy lab. But the papillary muscles are attached to the cords, which are the chordae tendineae. The chordae tendineae are then attached to the AV valve, so they're attached to the tricuspid valve and attached to the bicuspid valve. Whenever the ventricle contracts, the papillary muscle contracts, pulls on the cords, and it keeps these valves closed so they don't go up into the atrium. So damage to the papillary muscle on the left side of the heart means that it's not pulling on the cords, and now some of the blood can go back up into the left atrium because of this prolapsed valve. I included this slide in this PowerPoint just to show you that valves prevent blood from flowing backwards. The AV valves are the ones that are between the atria and the ventricles. It's the tricuspid and the bicuspid. And this is what they do. They attach to the chordae tendineae, which are attached to the papillary muscles, and they prevent them from going backwards. All right, part 3, cardiovascular involvement. Dr. Collins called Nurse Nan from the patient's room and confided, Mr. Helms is in bad shape. His left posterior medial papillary muscle was damaged from his heart attack. The papillary muscle is no longer able to maintain closure of the valve, and this has resulted in mitral valve prolapse. With decreasing cardiac output, this patient is in for a fight for his life. Nurse Nan knew that maintaining cardiac output was necessary for adequate blood flow through the body. As Dr. Collins walked away, Nurse Nan composed herself to tell Mrs. Helms the bad news and returned to the patient's room. Nurse Nan explained to Mrs. Helms that her husband had left-sided heart failure and that his blood pressure was slowly and steadily decreasing. So in question number 1 in part 3, in general, how is the direction of flow disrupted because of mitral valve prolapse? Well, if you look back at the flow of blood through the heart in general, if the mitral valve is not closing completely, blood flow will be reduced from the left ventricle into the systemic circulation, while blood flow will increase from the left ventricle into the left atrium. So in other words, blood will go back up into the left atrium, so we're decreasing how much blood is going to leave the left ventricle, so we're decreasing cardiac output out from the left ventricle. We're increasing the pressure of the blood going back up into the left atrium, which is going to increase the pressure of the blood in the pulmonary circulation. So, number 1, under part 3, how is the direction of blood flow disrupted? Well, some of the blood is going to go back up into the left atrium. Number 2, does the mitral valve prolapse increase, decrease, or not change the stroke volume? Well, stroke volume is when you take the end diastolic volume and you subtract the end systolic volume. That is stroke volume. We are decreasing the end systolic volume. If we decrease the end systolic volume, because not all of it's being ejected, some of it's going up into the left atrium, that's going to decrease the stroke volume. So stroke volume is decreased. Some of you put increased, but stroke volume is going to be decreased because there's not going to be enough going into the systemic circulation. Number 3, how does mitral valve prolapse decrease cardiac output? Well, if stroke volume is decreased, I'm going to try to put a little arrow down here, then that's going to decrease cardiac output. And some of you put increased on that. Some of you did right on the stroke volume, said it decreased, but then you said that cardiac output was increased, which didn't make sense. If stroke volume is decreased, so is cardiac output. And you can remember that using this formula right there. Number 4, explain how cardiac output determines blood pressure. It has to do with this formula right here. The mean arterial pressure, which is blood pressure, is equal to cardiac output times resistance. So if cardiac output decreases, then your blood pressure will also decrease, which is why one of the compensatory mechanisms for the cardiovascular system, if there's been a decrease in blood pressure, is vasoconstriction. Vasoconstriction will increase resistance, which will then increase your blood pressure back up. So number 4, explain how cardiac output determines blood pressure. Well, they are directly related. So if one goes up, so does the other. In this case, cardiac output went down, so did his blood pressure, which we remember from part 1, his blood pressure was something like 90/52, which is a lot lower than 120/80. And then number 5, why is Mr. Helms' heart rate higher than normal? The reason why the heart rate is higher than normal is because it is trying to compensate for the low blood pressure. When there's low blood pressure, then there's not enough oxygen, or there's a decreased amount of oxygen getting to the brain. So the brain then is going to signal the SA node to speed up so that we increase the heart rate to help compensate for the lower than normal blood pressure. All right, part 4, pulmonary involvement. Mrs. Helms was very upset with the news of her husband's condition. As the day progressed, she noticed that Mr. Helms's breathing was increasingly difficult. He could barely speak without losing his breath. Mrs. Helms called the nurse to her husband's room. "My husband can't breathe. What is wrong? I thought he had a heart attack, not a respiratory condition." Nurse Nan auscultated, which means she listened, to the patient's chest, listening to Mr. Helms's respirations, which were rapid and wet, producing rails or crackling sounds. Nurse Nan calmly informed Mrs. Helms, "I'm sorry, your husband's condition is worsening. The damage to his heart is causing his respiratory problems." So we have a new word here that we may not have heard before, and that is rails. Rails is a wet breathing sound, and if you've ever heard somebody with rails, you can hear it without even using, if it's bad enough, you can hear it without using a stethoscope. It sounds like they have liquid in their lungs as they breathe in and breathe out. It sounds like they are drowning. It's a horrible sound, one of the worst sounds in the world, I think. Anyways, look at the questions. Number 1, The left side of the heart receives blood from which part of the body? Well, this harkens back to the flow of blood through the heart and the pre-lab that you did. So the left side of the heart receives blood from the lungs. So it receives it from the pulmonary veins. Question number 2. If the bicuspid or mitral valve is not fully closing, does pulmonary circulation increase, decrease, or not change? So in number 2, let's think about this. If the pulmonary blood pressure, if the mitral valve is not fully closing, does the pulmonary circulation increase, decrease, or not change? Well, if some of the blood is backing up into the left atrium, then blood is backing up into the pulmonary circulation, which is increasing resistance. And anytime you increase resistance, you decrease the flow. So circulation is going to decrease with the mitral valve is not fully closing. Some of you put increased or not change. So number 2, if the mitral valve is not fully closing, the pulmonary circulation will decrease. And then we have question number 3. Does pulmonary blood pressure increase or decrease with left-sided heart failure? Well, we've already decided that pulmonary circulation decreases because blood is backing up. If blood is backing up into the lungs from the left side of the heart, from the blood coming in from the right side of the heart, then we have less blood going out than there is coming in. So that's going to increase pulmonary blood pressure. So number 3, pulmonary blood pressure will increase, and it's because of the blood that's backing up from the left atrium. And then question number 4, does this change in pulmonary blood pressure increase or decrease capillary filtration in the lungs? And they want to explain. And then I'm going to have a picture on the next slide, so it helps explain a little bit, but I'm just going to go ahead and do questions 4, 5, and 6 before I go to the next slide. Anyway, so does this change in pulmonary blood pressure increase or decrease capillary filtration? Well, the driving force behind capillary filtration, if you've done the pre-lab and the case study for capillary filtration, which is the next case study, then it's hydrostatic pressure. So hydrostatic pressure, I'm just going to put hydro, causes capillary filtration. So if we have an increase in the blood pressure, which means we have an increase in the hydrostatic pressure, that means we're going to have an increase in the capillary filtration. So number 4, the answer is it's going to increase capillary filtration. It's because we've increased the hydrostatic pressure of the pulmonary circulation. All right, number 5. It says, how does this change in pulmonary blood pressure and capillary filtration cause his rales? And rales is that wet breath sound. Well, if there's been an increase in the pulmonary hydrostatic pressure and an increase in pulmonary filtration, the osmotic pressure of blood, which pulls fluid back in, is not going to be adequate. There's going to be more fluid leaving the circulation than coming in. So fluid is going to accumulate in the tissues of the lungs. So fluid is going to accumulate around the alveolus, and it's going to actually separate and increase the distance between the alveolus and the pulmonary capillary, the more fluid that builds up in the lungs. So number 5, how does the change in pulmonary pressure and capillary filtration causes rales? That has to do with the amount of fluid that is surrounding the alveolus, and you can hear the gas exchange through the liquid in their breath. Then number 6, why is Mr. Helms breathing rapidly? Well, he's breathing rapidly because with the left-sided heart failure, there's a decrease of blood flow through the pulmonary circulation. So if there's a decrease in the flow of the pulmonary circulation, then there's a decrease in the amount of oxygen that's going to be available for the tissues. So oxygen levels are going to drop. Carbon dioxide levels are going to rise. And then the sensors that are in the respiratory center of the brainstem are going to sense this rise in carbon dioxide. So it's going to increase your breathing rate in order to compensate. So for number 6, just to rehash, your breathing rate increases because the brainstem is trying to compensate for your low oxygen levels and your rising carbon dioxide levels. This is a picture from chapter 15, talks about capillary exchange. So anytime there's a capillary bed, there's an arterial end, and then there's a venular end. And there are 2 pressures that are in charge at any given time during the capillary bed that causes filtration or absorption. Filtration is the movement of fluid from inside the capillaries to the tissues. Absorption is moving anything from the tissues back into the circulation. So the driving force for filtration is the hydrostatic pressure. The driving force for absorption is going to be the osmotic pressure. And typically, hydrostatic pressure is higher at the arterial end and lower at the venular end. But whenever there is pulmonary edema and there's a backup of blood and the hydrostatic pressure is higher, that's going to turn this hydrostatic pressure a little higher way up here. But the osmotic pressure is going to stay the same. So now we're going to move this X over further to the left. I know I'm getting a little more complicated than it should be. Just know that hydrostatic pressure is the driving force for filtration. So if this hydrostatic pressure goes up, filtration goes up as well. And since there's no compensatory mechanism for bringing the extra fluid back in, fluid starts to build up in the tissues. And if we're talking about the lungs, then it builds up around the alveolus. This picture is from chapter 18 of the book. I'm going to show this right here, pulmonary edema, what's happening. Fluid is building up around the alveolus and it's separating the capillary from the alveolus, and in so doing, we're increasing the diffusion distance so that it takes a lot longer for oxygen to diffuse through the fluid and get into the circulation, and for carbon dioxide to leave the circulation and get to the alveolus. So when we increase the diffusion distance, diffusion rate goes down. So oxygen levels are going to drop, carbon dioxide levels are going to rise. Part 5, renal involvement. The next morning when Nurse Nan started her shift, she immediately checked on Mr. Helms. His cardiovascular and respiratory conditions were still deteriorating, but Nurse Nan discovered something new. Mr. Helms's urine output was almost non-existent. Nurse Nan informed Dr. Collins, who was gravely concerned. Dr. Collins met with Mrs. Helms to tell her that her husband could not survive kidney failure. Mrs. Helms looked shocked. She then became very upset and angry. "What did you do, Dr. Collins? My husband had a heart attack, but his kidneys were fine. He's never had a kidney problem. How could you let this happen?" Nurse Nan put her arm around Mrs. Helms's shoulders, and Dr. Collins handed her a tissue. Dr. Collins explained, "The damage to your husband's heart is very serious. The kidneys rely on blood pressure to work, and his heart failure is causing the kidney failure." So question number 1, what are the functions of the kidneys? And most of you did this just fine. The kidneys filter wastes from the blood and they form urine. The kidneys also regulate your fluid levels, your electrolyte levels, and they also have something to do with your acid-base balance. Number 2, what is the force that causes the filtration of blood by capillaries in the kidneys to occur? And a lot of you missed this one. The force that causes filtration is your hydrostatic blood pressure, your systemic hydrostatic blood pressure, because we're talking about the kidneys, which is systemic and not pulmonary. So the force behind filtration by the glomerulus is going to be your hydrostatic blood pressure. So a lot of you put Starling force, and I tell you, I had to look that up because I have never talked about Starling force. It's not in the book. I've looked all through the book. I even did the e-text and did a search for Starling force, and it's not in there. There's the Frank-Starling equation, which has to do with blood into the heart is blood out of the heart, and that sort of thing. But this is not talking about it. So I don't know where you came up with Starling force. I'm going to assume it had something to do with Google, but I don't know. Don't call it Starling force. It is the hydrostatic blood pressure of the systemic system. So number 3, does left-sided heart failure increase, decrease, or not affect kidney filtration? Well, with left-sided heart failure, we have a decrease in your blood pressure. There's a decrease in your static blood pressure. So if there's a decrease in the blood pressure, then there's going to be a decrease in kidney filtration. Remember, his systemic blood pressure was only 90/52. The blood pressure has to stay at a constant rate in order for there to be a constant glomerular filtration rate. But at some point, if you remember from the urinary system and that PowerPoint, at some point when your blood pressure gets too low, it's not enough for there to be a filtration rate. All right, this is showing you the glomerulus. We have an afferent arteriole going in to form the glomerulus, and then efferent arteriole coming out. Your blood is coming in through the afferent arteriole into the glomerulus. This is where filtration occurs. So the force that forces filtration is going to be your hydrostatic blood pressure coming from your systemic blood pressure. It forces filtration. So if the blood that's going in here is at a low pressure and it cannot overcome the osmotic pressure and the fluid hydrostatic pressure of the capsular space, then there's not going to be any filtration out into the tubule. Part 6, resolution. Dr. Collins rushed Mr. Helms into surgery for valve replacement. Mrs. Helms waited anxiously in the waiting area for family for hours until she saw Nurse Nan coming toward her with a big smile. Your husband is in the recovery room. He's going to be just fine. Mrs. Helms sighed with relief and gave Nurse Nan a big hug. Questions. Number 1. How would you expect Mr. Helms's vital signs and respiratory and kidney functions to change after valve replacement surgery? Explain. Well, I think it is a little bit of common sense. You would expect all of his vital signs and all those functions to return to normal because now the blood flowing through the mitral valve, it's going to go just one way. None of it's being backed up into the left atrium. So his vital signs return to normal. His blood pressure returns to normal. When the blood pressure returns to normal, so does your kidney function. So now we can have a normal filtration rate. Well, if the vital signs are normal, a heart is beating normal, then there's enough oxygen getting to the tissue, so the respiratory rate will go back down to a normal rate. So number 2, now that you are familiar with left-sided heart failure, describe blood flow with right-sided heart failure. And some of you didn't get this right. So with right-sided heart failure, just like with left-sided heart failure, there's blood that's backing up into the atrium. But now, since it's the right side, we're talking about a prolapsed tricuspid valve. So now some blood is backing up into the right atrium, and there's a decrease in blood flow going into the pulmonary circulation. So that's what I was looking for there. Number 3, what are some possible causes of right-sided heart failure? Now this is probably something you did have to look up either on Google or in your book. But some possible causes of right-sided heart failure could be a pulmonary embolism. An embolism is a clot that has been dislodged and now it's lodged inside of the pulmonary circulation. So if there's a clot that's preventing blood from getting into the lungs or into the pulmonary circulation, then it's going to back up into the ventricle and actually back up into the right atrium as well. So pulmonary embolism. Believe it or not, left-sided heart failure can cause right-sided heart failure as blood backs up into the lungs. Anyway, or you could have also said a tricuspid prolapse, either way. So then the last question, what symptoms could be expected with right-sided heart failure? Well, with left-sided heart failure, we saw his symptoms. He was breathing rapidly. He was, his systemic blood pressure was too low. So what would we expect with right-sided heart failure? Now we would expect your systemic blood pressure to be high. And if the systemic blood pressure is high, then we would expect fluid to build up in your tissues. Just like the fluid built up in the lung tissue, now we have fluid building up in other tissues, and that's going to be evident in the extremities. So you're going to have swollen arms, maybe swollen feet and ankles. Those are all common with right-sided heart failure. You could have swelling of the abdomen, that's called ascites. So you can have all that tissue swelling or that fluid swelling up in the abdomen as well. All that can happen with right-sided heart failure. All right, so if you have any questions about this case study, please email me.